Welcome to Free Flow, the Health Tech Law and Policy podcast, where we explore developments in health policy and help you navigate legal and compliance issues that affect your business. I'm your host, Dan Orenstein. In today's episode, we're joined by Aaron Neiderhiser, CEO and co-founder of Tuva Health, an open source platform that transforms raw healthcare data into actionable intelligence. Since its founding in 2022, Tuva has been adopted by leading payers, providers, and high-growth innovators, including MultiCare Health System, Cone Health, Oscar, Clover, JP Morgan, and more than 60 others. Hey, Aaron, how are you? Welcome to Free Flow.
Good, Dan. Thanks for having me.
Thanks for coming. And it's great to see you, and glad you were able to join the show. I would love to start with, you're the CEO of Tuva Health. We're going to get into that in a minute, what your company's doing, what your mission is. But I'd like to start with some personal information about you. How did you, first of all, how did you wind up in Salt Lake in the Mountain West? And give me a little bit of that background.
Yeah, I mean, so I've been in Salt Lake. This was, I think, our 11th summer. So been here about 11 years. I'm from Iowa originally. So born and raised in Cedar Rapids, Iowa, Eastern Iowa. Lived there for the first 23 years of my life. I went to college there, went to a small liberal arts school. There's tons of like really kind of cool small liberal arts schools spread out all over Iowa. So went to school at Coe College and played tennis there and studied economics. And then I was actually like most interested growing up. I was like very interested in investing.
Yeah.
And always thought
so that was an interest from an early age.
Yeah, like I would say I remember being like 10 years old, and actually when I was 9, my grandpa was really into the stock market and investing, and he like came up with this game that he called Grandpa's Brokerage, where he gave me like $200 of like, pretend money. And he was like, just go invest in some stock, buy some stocks and kind of manage a portfolio, like on a piece of paper, nice. Right. Made a spreadsheet with a ruler. And then the deal was that like any profits that I made from that portfolio, he would pay me in real money. And so I did pretty well in the stocks that I bought, and then I was kind of hooked after that. And so your
grandfather influenced you, and then you kind of decided to pursue a career in institutional finance based on that, or with a few things in between.
Yeah, I mean, pretty quickly I was like, got a paper route and was shoveling all that money into an E-Trade account and buying mutual funds, and so. That was really, and then, went to school for economics because I was really on that kind of trajectory. But then I finished undergrad, and this was kind of the height of the financial crisis. So I graduated in 2008. And I was kind of like, well, I could go to like a big financial center like Chicago or New York. And I'd lived in Chicago one summer. I had an internship at the Board of Trade. And so I knew I could go back there and try and, live in the city and do something like that. But one of my friends had moved to Denver, and he was like, hey, why don't you come out? Like, I don't know anybody out here, but it's really cool out here. Why don't you come out here? And I've always been a big cyclist from a young age, and something about like riding my bike in the mountains was always like really attractive to me.
Appealing vision. And Aaron, I think you mentioned that you did the RAGBRAI. Did I pronounce that right? In Iowa, like a whole bunch of years in a row?
Yeah, like 7. So Iowa has this annual bike ride across the state called RAGBRAI. It stands for Register's Annual Great Bicycle Ride Across Iowa. And it's been going on for like, I think the first one was like 1970. And so now it's, over 50 years now. My dad actually did the first couple of rides when there were just 100 people, 200 people that did it.
Wow.
Now there's like 15,000 people that do it every year. So it's
is that a grueling ride because it's like in the heat of the summer?
It can be, yeah. I mean, they do a different route every single year. There's like there's 7 overnight towns, right? So you ride kind of like about 70 miles a day, and and so depending on the route that they choose, it can be less hilly, more hilly. longer, shorter, and then the weather is obviously a huge factor.
So what's a memorable moment you've had on the RAGBRAI?
Oh, that's a good question. I mean, I started doing this when I was 10. I remember when I was really young doing it, my dad always made fun of me because I would just be so tired that I would get done and I would just take like a 4 hour nap, and then, we'd go eat dinner, and then I'd be able to come back and go right to sleep again for like another 10 hours. And he was always just like, "Oh my God, if only I could sleep like
That's a
that."
big
Like,
advantage.
yeah. So he would just find me like passed out on couches, like face down, like, in church, we would often stay in churches kind of,
Hmm.
and so we would be like, I'd be like face down in a pew somewhere, just like asleep.
Nice. And so going to Denver, that was an opportunity to continue cycling and then become like a mountain cycling person.
Yeah, I mean, I was really interested in, kind of, I don't know, something, there was like an allure, some allure of the mountains. And
Yeah.
so I knew, but I knew I was also, I think implicitly, I also knew like, hey, Denver's probably not a big financial hub, right?
Right.
So I was kind of like putting that on hold a little bit. But yeah, that was kind of the main
Yeah. And
allure.
so then tell me how you got into healthcare data, because that wasn't your or your grandfather's plan for you.
No, no. So I was kind of like, got to Denver, was working some jobs that, just like temp jobs and different things that weren't that great. Was trying to figure out a plan, and I decided to enroll in grad school in economics at UC Denver because I always really liked economics and was kind of like, oh, that's, part of the finance investing
Right.
trajectory. And then I was wrapping that up, and I was looking for jobs in investing in finance, but there's like hardly any in Denver. And so I talked to one of my professors, and she had done a bunch of consulting with the state of Colorado for state Medicaid. And she told me, hey, like, if you're looking for something, these guys at Colorado Medicaid really need a good data analyst. You should go talk to them. And I was just like, that sounds dumb. I'm not interested in that at all, but I have no other options at the moment. So I will go do that. And it really turned into, it was really one of these like reality minus expectations sort of things where I was just like, I'm going to take this meeting and that's going to be the end of it. Right.
Yeah. So did
And
health data like immediately captivate you, or did it take a little while?
well, the thing that was very interesting about it was, I took this meeting and they're telling me about, how they're trying to set up this statewide accountable care organization, and they're trying to change the way we pay for how care is delivered. They told me about fee for service. I'd never had any significant interactions with the healthcare system, and so I didn't really understand any of this. And that was interesting. But then the thing that really piqued my interest was, they were saying, and we've got 20 years of longitudinal claims data on over 1 million people, and we need to use that data to operationalize the program. And that was just, as a data analyst, you're like, longitudinal data is very interesting in general, in terms of like, as opposed to like cross-sectional data. And I don't know what it is, but I did have this kind of inherent interest in kind of like health and like disease and drugs and different things like that. And so the idea of like a data set, a longitudinal data set that was tracking all that stuff, was very interesting to me.
Hey, Aaron, maybe you can just really quickly explain the difference between longitudinal and cross-sectional data for the listeners.
Yeah, I mean, so like a cross section of data, like let's say you had data on, like, let's say you were measuring like average income by state in the
Right.
US, right? And so you had average income for every state in the United States, and let's say you just had that for 2007. That is a cross-sectional data set.
Right.
Now let's say you have that same data set, but it's not just for 2007, it's also 2008, 2009, 2010. Now you're tracking by state over time. That's a
Is
longitudinal data set.
continuing over time essentially is
Yeah.
longitudinal. And that's really important in healthcare because all of that data tells a story about the patient and their care, treatment,
Tell
diagnosis.
over time for the same entity of interest, right? So if
Yeah.
the state is the entity of interest, over
Hmm.
time for the same state. If a person is the entity of interest, over time for the same person, as opposed to just time series data where there is no entity or there in the data set.
Right. Right. So you're working for the state of Colorado and you decided to stick with the field. And is that when you started considering yourself a health data scientist, or did that continue to evolve?
Well, that's when I started learning about claims data and how to analyze claims data and how to do good data analysis. I think I kind of had like I still had one foot in my first couple years there. I still kind of had one foot in the investment world, and I was going down I was starting to take some of the actuary exams. And that's when I started to think, okay, maybe I could be a health actuary, but also I could leverage the actuarial exams in finance too. So I still kind of had a foot in each world. But then after 3 years, I started working more closely with some of the analytics vendors the state contracted with. And that started to be particularly interesting. Like healthcare analytics I really started to see myself doing that potentially longer term.
Yeah. Yeah. Terrific. And then, you know, you had a career in health data science and analytics. And let's just fast forward to Tuva Health so we can get into that. So, what is how did you come up with the idea for the company and the concept of Tuva Health?
Yeah. I mean, what we do at a high level is we're building open source software that transforms raw healthcare data, like payer claims, EHR data, other types of clinical data, into analytics ready data. And there is a kind of laundry list of different tools that you need to do that. It's impossible to analyze raw healthcare data. The
Right.
simple example that I use if I'm talking to like my mom is, you would think your health system knows how many people took Tylenol last week.
Hmm.
Well, they don't because Tylenol is made up of almost 700 different 11-digit alphanumeric codes that change all the time.
Right.
And there's not good governance around these codes, right? And, you might think, well, that's kind of a silly question. Like, who really cares about, like, who took Tylenol last week? But that's true for any question. Even more interesting questions like who was readmitted, how many ED visits did we have, who has this disease, that sort
Yeah.
of
And
thing.
and how did you identify the problem with that data transformation?
Just through experience. Just like,
Yeah.
I mean, almost immediately getting, when I started my work as a data analyst at Colorado Medicaid, you just start working with claims data and you're just like, I personally was very excited to get into the data. And you kind of immediately are just like the road to answering any interesting question from this data set is like 1,000 light years away, sort of.
Yeah. So something that's unique about Tuva is you're doing this on an open source basis, at least the core transformation data model
Yep.
technology, right? How did you arrive at that and why is that important?
Well, before starting Tuva, I'm best friends with my co-founder Coco. We both moved to Salt Lake City around the same time, and we met downtown playing squash. And pretty much ever since then, Coco also works in healthcare data science. Prior to starting Tuva, I was at Health Catalyst. Coco was leading data science at a company called Strive Health, and we were just talking about the things our teams were working on. And Coco's like me, where we're both like very interested in answering questions from healthcare data. Like there's
Right.
so many cool questions you could answer. Like, what questions are we answering? And every time it was kind of like every time we were getting together, like no one's answering any interesting questions.
Hmm.
We are all building the same tools to manage the transformation of the data to get to the point where we could answer interesting questions.
So you're
And
spending way too much time on the transformation and data management and not enough time on data analytics research and interesting questions around the data.
exactly. And the thing we basically were like, look, there's so many people like us out there. There's so many more healthcare data engineers, data scientists than there used to be when we first got into the industry. These people are all gravitating toward modern tools. A lot of those tools are open source, but there's nothing none of they don't have any of the healthcare data specific tooling baked into them. So what if we open
Right.
source this set of tooling? Then those people would have something that they could use, and that would lead to a lot of adoption as Tuva as kind of the standard data model for healthcare analytics.
Right. Why do you think it took so long, maybe not so long, but for you and Coco to do that, to have that insight before someone did that in healthcare?
Well, I think they're like open source is like a tricky, like it's a trickier business to build
Right.
because like what we've done at Tuva is we've raised a little over $5 million in venture capital, and then we have spent that building a product that we are giving away for free.
Right.
Right. And so
So
like
it's not like, immediately the most obvious business model that you want to pursue.
exactly. It's harder. The kind of startup costs are a lot more difficult. We think the longer term payoff is worth even more, but you've gotta be willing to kind of like go through that pain and have a vision for how to get to it. And I think that's really tricky. And I think we've worked in the space now for about 15 years, each of us, and I think we were really familiar with the problems. It took a while to get to the point where we were like, hey, we think we can actually solve this better than other people.
Sure. So when you engage with a client, and who are your typical clients?
It's basically the entire healthcare ecosystem. There's major health systems using
Right.
Tuva, multi-care health system, Cone Health, payers like Oscar or Clover, a lot of ACOs, a lot of tech-enabled services companies, digital health companies like Hinge Health, Included Health. And so it's employers use us. So it's a lot of different types of organizations. Usually what happens is somebody on the data team, and that could be a more junior or more individual contributor person, or it could be like the head of the data team. Somebody on the data team discovers Tuva, and usually when they're discovering Tuva, they have a desire to be like kind of taking control of their data platform. They may have some previous homegrown thing, but they're like, hey, we're moving all that into our Snowflake, or we're moving all that into our Databricks, and we want to have control over it. And if we ever talk to somebody like that and they learn about Tuva, their eyes get really big because they're
Yeah.
like,
So
wow,
the way you engage with clients is you bring your open source software into their environment.
yes,
They're not accessing you over the cloud.
which is different than other vendors where usually you have to send your data out to somebody else.
Right. So they kind of keep custody domain over their data, but they have a modern open source data system. And then you also provide help with the data transformation and analytics. Maybe talk about that for a minute.
Yeah, we basically provide closed source products and services around the open source platform. So
Right.
the customer uses our open source kind of data transformation data model inside their cloud data warehouse, but then they'll have different problems they kind of need to solve around that. How do I get my data into the data model? Other point solutions like enterprise master patient index, NCQA HEDIS measures, risk adjusted benchmarking. And so we help them solve those problems kind of around the core open source.
With health systems and providers moving more towards cloud-based solutions, is that your approach a little bit different? Do you get a little resistance to that, or is that something that's still very much alive, like CTOs wanting to maintain control over the data in their environment?
Yeah, I think everyone's moving to cloud or almost 100, not I would say like 98% of organizations we engage with have their data in the cloud, but
Yeah,
it's their cloud as opposed to a vendor's cloud.
right.
And so there is still there's a big desire to not have to be sending data outside of your cloud to somebody else.
Sure, sure. Got it. And let's talk a little bit about the data sourcing as a segue here. So you work with your clients to implement your software in their environment. On the data access side, kind of getting into some of the policy environment here, what has worked well? Still presents challenges in terms of acquiring that data access?
I like to think about data access in terms of are we talking about access to like an individual patient's data, or are we talking about access to a population,
I think
right?
both. Let's hit them. Yeah, yeah. Let's hit
And
them
and I
both.
I think things like first century cures have been very helpful for individual access,
Hmm.
less helpful for population access, although that is starting to change a little bit. When organizations that we work with are getting data, there's a few different types. One is payer claims. And that's usually through relationships they have with other organizations, kind of like at-risk contracts with other health plans or something like that. And the way they get those data sets is almost always flat files like CSVs
Right.
delivered over SFTP. And these files all come in different formats, different shapes, different sizes, different data quality problems, and they change all the time. And there's no governance around this or no standardization around this at all. And the one exception to that is probably if you're getting data from CMS, like if you're a
Right.
Medicare ACO, CMS has done good standardization around their process. Initially, they just had they were also delivering flat files, the fixed width CCLF files. But in the last couple of years, they've turned on a FHIR endpoint, a bulk data FHIR endpoint called BCDA, which stands for Beneficiary Claims Data Access API. And
Hmm.
now increasingly organizations that we work with are pinging that API and getting population scale claims data in FHIR format via that API. And so I think that's where you're just finally starting to see, at least on the payer claims side, the kind of FHIR data access.
So do you think the policy efforts to encourage adoption of Fire and other APIs and standards have helped with that process, or are there still challenges or things that the federal or local governments should be doing?
I don't think it's helped tremendously on like the population side of things.
Right.
I think it has helped quite a bit on the patient side of things. Like, I need to, I need to get this particular patient's like medical record or do something with prior
So on an
auth or
individual patient basis, it's been helpful, but not on the population level data that you're
not a
trying
ton
to
on the
access.
not a ton on the population level. I mean, like, so another area where it has been helpful on the population side is you have vendors that are providing access to real-time clinical data. These are companies like Metroport or Zeus or Particle
Hmm.
or Health Gorilla, and they will provide bulk access to FHIR data on for clinical data. And so I think that if you want to engage with a vendor, there's that path. If you want to get bulk data via claims, you can get it through CMS through the BCDA. But if you want to get bulk data, payer claims from another payer, you're basically getting this random set of CSVs delivered to you, right? And that's across hundreds of health plans, and so
So
that's
that's
what's not
challenging for
working.
you to transform that population level data.
Yeah, a lot of the work that we do for customers is they get random claims data set and we help them connect that into the Tuva data model.
Over the next 5 years, do you see the policy environment getting better and helping with the population level data or not?
I don't have a good read into that. I think the incentive until there's like a very clear incentive to go with whatever the regulatory thing is. I think like
Right.
there's this like kind of business as usual kind of inertia in health plans that sort of like leads the way. And so I think you got to crack the nut on both of those things. Honestly, it's one of the things that potentially Tuva could help solve. There are a number of organizations that have adopted Tuva that have decided now when we have to share population data, we just share it in the Tuva format. And
Right.
we hear that a lot. So
So that would be great if that starts becoming a standard, then it'll make your life easier.
could be good. Yeah.
The information blocking rules under the 21st Century Cures Act, have you seen that being a tailwind to help you get access to information at all?
Not specifically because a lot of the organizations that we work with are already covered entities.
Right.
Right. And so I would say maybe the one example is just getting easier access to data from their EHR, whoever the covered entity is,
Right. Right.
making it easier to extract information from their EHR. That might be the one example. It doesn't
Hmm.
really help as much with that payer exchange of data from like
I see.
from a health plan to an at-risk provider.
Right. How about employers? As you work with employers, that how's the environment there in terms of data access?
Yeah, that I think is an area that's ripe for more kind of top-down like level setting because there's kind of two types of employers. So employers like basically every employer should have access to their claims data and
Right,
be able, like, it's their data essentially, right? But often what happens is they don't have direct access to it, and either the broker or the TPA or whoever is the one that has it. And they aren't always friendly about enabling the employer to have access to it. And increasingly, the employer has a need to access that data and share it with other partners. Like if the employer buys a digital health service for their employees, right? Like think Hinge Health or Included Health for care navigation or something like that.
right.
Or if the employer just their like benefits team wants to do advanced analytics to understand how they can provide better benefits for their employees, that would require claims data. But oftentimes what determines whether or not the employer can get access to their data is just how savvy they are in asking for it and negotiating for it, and how agreeable or reluctant the broker or TPA is to share that data. And so it would be we see organizations on both ends of the spectrum that are like we're an employer and we get all our claims data and everything is, relatively organized. And then we see employers that are like, we've been trying to get the data for like 18 months and they won't give it to us. And
Yeah,
and so
yeah.
that's just ridiculous. And so I think some like more top down, like kind of like, kind of policy, making policy clear there would be like very helpful.
That's a great point. Yeah, it seems like in the data exchange world in healthcare, a lot is left up to individual parties and players to figure things out on their own. And it's more of a laissez-faire system than we see in some other countries that have taken a little bit more of a directed or top-down approach to data exchange and access. It's the US
100%.
system. So
Right.
that's what we're living with, and that's the environment you're in, and you're in the business of loosening that up and acquiring the data that you need to uh, to do the analytics and answer those questions for your clients.
Yeah, I would say at overall at a high level, data access is much better than it was 10 years ago. And that's a little bit of why Tuva, if you think about, kind of the healthcare analytics value chain at the highest level, you think data access, data transformation, insight generation. If you can't get access to the data, nothing else really matters.
Right,
And
right.
so most organizations that we work with today, we're live in more than 60 organizations across the country. Most of them have access to a dozen different healthcare data sources. And I would say like a decade ago, it was more the case like, okay, I've just got my EHR or I've just got my claims data set. So it is becoming more and more common to get access to more and more sources of data, but it is still the case that some of those sources are particularly hard. They're hard fought to get.
Right. But you're finding that among your client base, they generally have the data access they need to answer the questions that they want to answer once you do
At
your
least,
work.
yeah, at least to get started. Yeah.
Right. Okay, terrific. So I'd like to shift gears a little bit to you as a CEO, entrepreneur in the health analytics field. So, what have been some of the challenges that you've seen kind of on the legal compliance side, and how have you addressed those? Thinking about what would you have liked to have known as a founder starting, and when did you start Tuva Health?
Coco and I started Tuva on April Fool's Day of 2021. Because if you're going to start a company, you might as well start on April Fool's Day.
Absolutely.
The kind of like current iteration of Tuva that you see today didn't really get going until January of 2022. So
Okay.
that was really the
23.
first
Yeah.
22.
Oh, 22. Okay.
So we've been working on kind of the open source, that was the first commits to the open source with January of 22. So 22, 23, 24, and now we're getting close to 3/4 of the way through 25. So 3 3/4 years at this point. One of the nice things about, there's with any company you build, there's easy things and there's harder things, right? One of the
Sure.
easier things for us, because we were open source, was the fact that, like, hey, this is all going to be implemented in your cloud customer. And so there's basically the controls that really matter from a privacy and security standpoint are ultimately the customer's controls.
Right.
And so
that makes the conversation easier about, okay, what is this upstart vendor doing coming in?
Yep,
taking my data.
That was a little bit easier, yeah, because we weren't taking the data, we were bringing the code to them. I would say, like, in general, healthcare data policy is, like, incredibly nuanced. And if you have, like, a good partner to help you navigate that, that's incredibly useful. So someone that, like, really understands and has experience in the space, or at minimum has, like, good contacts kind of in the space to get questions answered, that is, like, something that I would recommend if your company is, like, doing something very deep in the healthcare data space.
Yeah. Have your larger clients kind of challenged you in terms of security and privacy to a point where at any point you felt like, we're not ready to address the issues, we're not big enough or have enough scale? Or have they been pretty understanding and flexible in terms of that?
Not to the point where we've ever lost any business
Right.
from it. Like, they've definitely challenged us, as they should be.
Sure.
Right? But never to the point where we've lost any business. We are just sitting here today, like, we were fully HIPAA compliant, but we are not yet SOC 2 certified. We're not yet high trust certified. We have a roadmap and are working on those things with plans to be SOC 2 by the end of this year. I think if we weren't if we weren't SOC 2 and we were taking data into our cloud, that would be more problematic. But again, because of the open source and the fact that we're deploying it in the customer's cloud and it's ultimately their security
So that
control
allows
policy,
you to lean on their security and privacy systems a little more than maybe some other companies that are hosting data.
Exactly. And you could even argue that in some ways makes, like, SOC 2 not particularly relevant, but it's still sort of a stamp of approval that organizations want to see.
Sure. Do you have anything else for the listeners on policy or your journey at Tuva Health that would be useful, or anything that you wished I'd asked you?
I don't know. I mean, I guess if folks want to contact us, they can learn about Tuva at thetuvaproject.com or go to tuvahealth.com to learn more. We have a Slack community. We're building the world's largest community for healthcare data and analytics people. The Tuva Project Slack community.
Nice.
We've got about 2,000 healthcare data engineers, analytics engineers, data scientists in there today. So yeah, if you're a healthcare data person or you're interested in healthcare data or analytics, check us out.
Awesome. Aaron, thanks so much for your time. Really appreciate it and enjoyed having you.
Yeah, thanks for having me, Dan. This is great.
And that concludes our episode of Free Flow. Thank you for joining us today. For more information, please visit our website at orensteinlegal.com and navigate to the podcast page. Remember to subscribe or follow Free Flow on Spotify, Apple Podcasts, and YouTube so you never miss an episode or update. This podcast is for informational purposes only, is not legal advice, and does not create an attorney-client relationship. Thank you for listening.